Thank you, Dr. Diaz, for the introduction, and thank you, CurePSP, for having me today. Good morning to you, or good afternoon, depending on where you are. Thank you as well for joining me. I will be presenting physical therapy and exercise in atypical Parkinson's disorders. The topics we're going to cover today are going to include research updates, as well as the traditional motor symptoms that we find in progressive supranuclear palsy, multiple system atrophy, and cortical basal degeneration, along with the physical therapy implications and interventions that we provide, as well as general exercise recommendations. We'll go over some equipment options, as well as frequent transfers that I get asked about a lot as a physical therapist. All right, so to start with PSP, there isn't a whole lot of evidence, unfortunately, found in the research for therapeutic exercise in people with PSP. There have been some reported improvements in walking from 2 clinical trials. Typically, those walking trials involve some sort of device or structure that we can actually body weight support the patient, so take some load off. It makes it a little bit easier to walk and achieve the walking style that we want, or the specific gait that we need, depending on what deficits someone's having. And the effects of structured physical activity for people with advanced PSP are not known. So at this time, the research is limited. There's not a whole lot out there to guide us in terms of physical therapy and what interventions we should be doing. This is mostly because there's a lack of or a delay in diagnosis. So we don't have a lot of research, and it's hard to capture a lot of people at the same time to really give good, effective research. Okay, and then for MSA, we have some limited evidence for the effectiveness of physical therapy-specific interventions in the population. But with Parkinson's, we have a lot of research. So we have a significant body of research for PT and Parkinson's disease, which can be applied to the MSA with the subtype T. Unfortunately, on the other side, the MSA subtype C and other degenerative ataxias, we have limited guidelines and limited evidence that supports interventions in physical therapy with that. And then with CBD, again, research is limited specifically in rehab, but it suggests that PT can play an important role throughout the disease course. And I would say that's true for all 3 diagnoses. So anytime we have some sort of progressive disease, physical therapy should be consulted throughout in the event of changing function or changing status. Okay, so for PSP, the typical motor symptoms that we're seeing are gait changes, early postural instability, and early frequent falls. And typically those falls tend to be backwards, which is very dangerous. So we want to do everything that we can to limit those falls or work on trying to maintain that postural stability. A lot of people usually ask us what postural instability is, and it's the actual ability of you to maintain your equilibrium under a dynamic or static condition. So anytime we're preparing to move, or if we get bumped into by another person or a dog or a wall, we have to react to that balance, as well as just maintaining our static balance. So sometimes people with PSP will say, you know, I was just standing there and I lost my balance and I just fell backwards. Nothing happened. I wasn't moving. But that's part of the disease course. So that postural instability and those falls backwards. So those are really important for us to know so we can treat those. As well as slowed movement, some rigidity, so some difficulty moving, stiffness, as well as the vertical gaze palsy and the double vision that can occur early as well in the disease course. Those things are important to note because that is going to change how you maneuver through your environment. So learning compensatory strategies early can help you be more successful with your balance and your walking through various environments. The other one that we typically see is called dystonia. So that is a state of abnormal muscle tone that can result in a muscle spasm or some sort of abnormal posturing in the disease. We see this a lot in the feet and the ankles, which again can help or can feed into the balance and gait deficits that we see. So really important things to work on and identify. In MSA, you'll see some of the same features. So rigidity, you can even have tremor and some of that slowness or bradykinesia. Those things can also lead to that freezing of gait. So freezing of gait is typically something that we see in Parkinson's, which is why, again, in those last slides about research, that we can use similar interventions to treating MSA with people that have the bradykinesia, the rigidity, and the freezing of gait, because we have known interventions for those for people with Parkinson's. The other gait change that can happen in the other subtype is that ataxic gait. So a wider base gait, having to take small steps and move fairly slowly. It's very unstable and can put you at increased risk for falls. And again, not a whole lot of specific interventions that have been tied to overcoming the ataxia. We can also have anticollis, which is the forward head position. So posture training is really important, and stretching out the front side of your body and strengthening the back is important in trying to overcome that. As well as you'll see the postural instability and the falls are also seen with this. The biggest thing to note is the orthostatic hypotension piece. So there's not a whole lot that we can do from a physical therapy standpoint that is going to fix that issue. The biggest thing that we tell people is to make sure that you're drinking plenty of fluids. If you're not on any sort of fluid restriction for other conditions, you want to make sure that you are moving slowly anytime you are in a static position for too long and you go to stand up. So either lying in bed and you're getting up to the edge of the bed before you stand up to go. You want to make sure that you're doing those movements slowly, giving your body time to adjust. In addition to that, sometimes compression garments can be helpful. So sometimes we'll recommend, compression stockings or socks or even abdominal binders, because those things can help maintain the pressure and can help decrease that orthostatic hypotension. And then next is CBD. So what we see with CBD is the slowness and stiffness. Again, we have balance and gait changes. Clumsiness is a frequent motor change that we see, as well as the alien limb phenomenon. So this is what happens or can happen as the disease progresses. And it's an actual involuntary motor activity of a limb in conjunction with a sense of estrangement from that limb. So not only is my arm moving and I can't control it, but it also doesn't really feel like it's attached to my body or it's attached to me. This phenomenon, again, if it's more in the arm, then that can play a role into what we're recommending for assistive devices. So if you can't really use your arm or don't have control of that arm, then a walker may not be our best option. The other one there listed is myoclonus, and this is an abrupt spasm or a twitch. So it can come in various intensities, and it can affect, one muscle or a group of muscles. Again, if that happens, that's going to affect balance and walking, even if it's in the feet or the hands, if you're using a certain assistive device. So definitely things that we want to keep an eye on as the disease progresses. Okay, so for physical therapy, what do we do then if there's not a ton of research? Well, our main goals all the time, regardless of your diagnosis, are to maintain functional and safe mobility for as long as possible. We want to prevent and or limit the falls, as well as the injuries that can relate from those falls. The more you're falling, obviously, the more risk you are to having some sort of catastrophic event or, something that injures you that can be detrimental. And then lastly, we educate and train care partners to safely help people, with the disease. So there is no handbook written on this. Everybody presents a little bit differently. So it's important that you see your physical therapist anytime your function changes or you have a new caregiver or something like that, because we can address those issues as they arise. It's not uncommon that PT is going to be needed, at various times throughout the disease progression. So I'm an outpatient physical therapist. So here I typically see people, for an evaluation. We see what's going on, what things we need to be addressed. We work towards those goals. We always have specific goals in mind. Then once we reach those goals, we usually discharge. So again, depending on, where you are in the disease course is what's going to dictate those goals, as well as your personal goals and input, as long as they're realistic. Then once we meet those goals, we discharge. Then we know that you will likely come back in 3 to 6 months, and that's okay. We then can take the time to evaluate you again, see if you've had any sort of functional decline. And if you have, we can step in and do another course of physical therapy, or we can, address things, or hopefully you've been able to maintain your functional ability. And then depending on what things go, the physical therapist will determine, how the plan of care goes from there. We also know that physical therapy can significantly improve motor symptoms due to the one-on-one exercise aspect and the personalized exercise plan. So developing a plan for you even after discharge. So these are some of the interventions that we use or things that we are hoping to do when we have people for a course of physical therapy. Again, all patient dependent, all depends on your functional status and how you're doing. The first one is that high intensity interval training. So there's a lot of research coming out with Parkinson's disease specifically, and how important it is to get into the high intensity or vigorous exercise. Physical therapy, we can, be there and supervise you for that high intensity aerobic exercise, which can slow the motor symptom progression. We can use the body weight support treadmill training that we have access to in most clinics that I mentioned earlier has been shown to be beneficial. And we can also identify, if you're further along and your balance isn't very good, what other ways can we get your heart rate up, get you into that vigorous level of intensity to get the max benefits out of your cardio training, your aerobic training. In addition, we do strength training. So this can be functional strength training or traditional strength training with use of dumbbells or resistance bands. And improvements in strength and power can also impact motor symptoms, decrease disease severity, have improvements in functional outcomes, and then also improve quality of life. So we want to maintain this strength through the lifetime, and physical therapists can help adapt what that training program might look like as the disease progresses. Balance training, that's a big one. That's what people get referred to a lot for physical therapy. Again, especially in PSP, where we're seeing early falls with that postural instability. So with balance training, we want to improve the ability to maintain your balance in various environments and decrease your overall risk of falling. With the balance training, we want to put you in various conditions, and that can sometimes be pretty uncomfortable for people, but you want to keep in mind that we are there to push you. We're there to provide support, that you are in a safe environment, that you will not fall, but we need to push you a little bit in order to make those adaptations. Okay, and then gait training. So it's important to maintain a normalized gait pattern, either with or without your assistive device early in the disease. And we can also use gait training to improve balance, gait efficiency, and decrease risk of falling. So gait training, a little bit different than the high intensity interval training or that aerobic training, because we're specifically looking at how is this person walking? What can we do to make them more safe? And again, if we're looking at physical therapy across the lifespan or through the progression of the disease, that gait training may differ based on what assistive device we're recommending at the time. Most of the time, we don't just recommend one assistive device and that's good for the rest of time. Most of the time, we're using something, then progressing to something else and progressing to something else. So with that, there's different gait patterns that may need to be learned in order to use those devices safely. In addition, we can also do task-specific training. So this is where we're practicing strategies and specific tasks and activities to create more efficient and safe mobility in the home or work or community environments, wherever the case may be. With outpatient physical therapy, it is difficult to really recreate some of these task-specific things. So most of the time, it's something like bed mobility or car transfers or moving around in the kitchen. So what I try to do here is, if we're talking about bed mobility, what side of the bed is your head on? What side is your pillow on? What way do you have to roll in order to get up? How much space do you have? So I'm trying to recreate all those aspects. Same thing with the car transfer. As you can see, that can be kind of difficult when we're talking about a specific car at a specific height with the door, as well as the environmental constraints. If you're stepping out from a curb or on a slant or something like that. So really those task-specific training, if you have a lot of difficulty with that, sometimes home therapy is a great option because home physical therapists will actually come to your home. They have the exact setup that they need, and they can really see where you're having difficulty and practice those activities in those specific parameters. There's nothing better than, if you're having difficulty with something, you need to practice that exact specific exercise or activity in order to get better at it. So again, sometimes if you're having a lot of trouble in the home physical therapy might be a better option as opposed to going to your outpatient clinic. You can always come to outpatient clinics afterwards or graduate, or vice versa. If you're not doing very well with the outpatient physical therapy, you're having more trouble in your home, then you can always go back to home physical therapy. That kind of goes into the care partner training as well. So same thing, we're working in specific environments to work with whoever's providing care in the home, whether that's a paid caregiver, a spouse, or to someone, helping out. And we can make home modifications to create a safe and stress-free environment. So depending again on what the constraints are, could be size, could be just the amount of opening, how many, if you can even get somebody in to the bathroom sometimes to help you with your assistive device. It all kind of depends. So we do a lot of care partner training in the outpatient setting, but a lot of it can come again from the home physical therapy setting because those are your task specific in the specific environments that you need and live in every day. Another intervention aspect that we look at is called dual task training. So there's a lot of research with this one, again, with Parkinson's disease. So we like to pull from that realm of interventions that we know have proven to work. And with dual task training, it actually consists of a primary task and a secondary task, typically one being motor and one being some sort of cognitive demand. So I always tell people thinking about walking, talking, chewing gum at the same time. You're doing 3 different tasks, which can be difficult. We know that in these diseases, we lose that automatic ability to walk. So if I go to stand up from a chair and I start walking, but at the same time, I'm thinking about I'm walking to the kitchen and what am I going to have for lunch today? That's going to impact my walking. As opposed to if we reduce a lot of the distractions, focus solely on walking, our walking can actually be better because we're focused only on that. So same as with the balance training, dual task training can be a little bit uncomfortable for people. It is challenging, it is difficult, but we know that trying to challenge your body and your brain at high levels when you're in a safe environment can sometimes carry over into a real world environment. And that's where we're always practicing to be better at. And then lastly, we can make adaptive device or equipment recommendations. So depending on where you're at in the disease course, we can determine the need for equipment to improve safety and efficiency for care partners and patients. All right, for general exercise, so this depends on your functional status, where you are in the disease course. We want to maintain strength, flexibility, posture, and overall mobility. We know that general exercise can improve your sense of well-being, especially in chronic illnesses. It also has positive impacts on improving bowel function and motility, which can sometimes be issues, as well as promoting cardiovascular fitness and reducing overall stress levels. So these are the general exercise recommendations for people with Parkinson's. It was created by the American College of Sports Medicine, as well as the Parkinson's Foundation. And this is what they found to be the minimum, which is usually what people ask me is, what's the bare minimum that I should be doing? Again, these recommendations can be altered depending on what your functional status is. Aerobic activity, we want 3 days a week for at least 30 minutes per session of that continuous or intermittent, moderate to vigorous intensity. The higher the intensity, the better. And activities such as walking, running, cycling, swimming, and aerobics classes are beneficial to help hit that domain. Also strength training, which we talked a little bit about. So 2 to 3 non-consecutive days a week for at least 30 minutes with 10 to 15 reps for major muscle groups. You can break those up into upper and lower body. You can use resistance bands, dumbbells, anything like that. Then we have balance, agility, that multitasking or that dual tasking we just talked about, 2 to 3 days a week with daily integration if possible, just to make it a little bit easier on hitting all of these things, including multi-directional stepping, weight shifting, dynamic balance activities. We do know that yoga, Tai Chi, dance, and boxing have all been recommended and proven to be beneficial in people with Parkinson's. And then lastly, stretching. You'll see there that it's a greater than 2 to 3 days a week, with daily being most effective. We always want to be stretching daily to make sure that we are maintaining our flexibility and our movement. You can do that, with sustained deep breathing or as a warm-up to any other type of exercise that you may be doing. And again, this is really important because in a lot of, all 3 of those diagnoses that we discussed, you saw the rigidity or the stiffness or the slowness. So stretching is a good way that we can address those issues. And the key to maintaining good daily function throughout the disease course is just to continue activity through exercise. So trying to stay as active as possible. There are some precautions that I would want to throw out there. So you want to make sure that if you're standing, you want to be careful, either have someone nearby you or stand in the corner. So if you stand in the corner with my shoulders not touching the corner, but backed up to the corner, if I lose my balance, I'm just going to bump into the walls. I don't have a whole lot of room to go backwards or sideways. You can put a good sturdy chair in front of you as long as you have enough room to move. Obviously, if that's not an option for you, you can also do exercises in a seated or lying position. Your physical therapist can also help modify things for you if you need to in these other positions if they aren't as straightforward as you would think they are. And I get asked a lot that stationary bikes are great options. You can have, a regular upright stationary bike or even a recumbent bike that allows you to sit and you have a little bit more support. If you have specific questions for you, again, I always recommend consulting with your physical therapist. They'll be able to help you reach these exercise goals if you're having trouble. All right. And then for exercise opportunities, there's a lot out there. You may just have to look for them. So checking any local PT clinic or hospital, they sometimes have community classes, your community centers. There are personal trainers that specialize in neurological disorders. So they could carry out a home exercise plan, maybe developed by your physical therapist, and they can, even advance those. Physical therapy programs at universities are always looking for people to either, look at or help them out with their courses through either interventions or even just examinations. They also sometimes have adaptive programs, so adaptive exercise programs for the students to learn in treating neurological diagnoses. But in this case, it's more of, can we keep you exercising in an adaptive way? And then one great thing that came out of the pandemic is obviously the use of virtual stuff. So YouTube, if you even search for the Parkinson's Foundation channel, they do exercise classes every Friday. You can find one that may be interesting to you or meet your needs. If you're looking for specific chair exercises, you can just search chair exercises. They will come up. Also locally here at UCSD, we offer community classes virtually the first and third Tuesday of every month. The link is there, so you can click on that. If you feel as though you can't make it, so we're on the West Coast, so we are 11 a.m. Pacific time on those days. You can also find the recording. So all of them live on YouTube. We have, I don't know how many now, but there are a lot of options there. Again, it's designed for people with Parkinson's, but as long as you're picking something safe that you can do, it'll be a good option. And also locally, we have a clinic called NeuroLab 360, and they have a virtual membership. So even though they're based out of San Diego, they're doing Zoom classes, and you can pay for depending on a different subscription, but they are tailored to people with neurological conditions. So I just wanted to throw those out there. You can even search, again, your local communities, see what they have to offer. All right, moving into equipment. So I have the 3 standard kind of walkers on there that we typically see. The front-wheeled walker, least expensive, the one nobody really wants to use. Then we have the 4-wheeled walkers or rollators, and then the U-step walker. The U-step walker is going to be the one that we typically recommend if anybody's having postural stability issues or the tendency of falling backwards. So you can see it's kind of big, it's bulky. This is on purpose. So it's designed to be able to be more inside of the walker to give you more support, as well as if you are tipping backwards, it's gonna be really hard to tip that whole device backwards because it's pretty heavy. Insurance coverage varies, so check with your individual plan. We have success here getting U-step walkers for people from our movement disorder clinic that are covered by insurance. I have seen people use the 4-wheeled walkers, and they'll put cuff weights or kind of weight the front end a little bit. That works. I don't typically recommend that. I usually just jump to the U-step walker because I think it's better in terms of stability. The other thing to note with the U-step walker is the hand brakes. So it's a reverse braking system. So instead of squeezing the brakes to stop yourself, you're actually going to squeeze the brakes to engage or to disengage the brakes so you can move forward. That way, if the walker gets too far out in front of you, you let go, your walker stops. If you're having difficulty walking and need an assistive device, I always recommend, again, your physical therapist to kind of guide you through. Next, wheelchairs. You can go as low as a transport chair. That's just designed to move somebody from A to B, not designed for any sort of self-propulsion by the person or the patient. Then we have manual wheelchairs. They can be self-pay or covered by insurance depending on what you get. A standard run-of-the-mill is going to be steel. It's going to be a little bit heavier and harder to push, but cheaper. And then we have other wheelchairs that can be custom to patients, designed specifically for your needs. And then we go into power wheelchairs. These you are going to be mostly covered by insurance. These can run up to $40,000 depending on the features. You also have to have a way in order to transport this chair. So you'll need a PT evaluation. And usually there's collaboration with a vendor to help you get one of those. There are different drive mechanisms as well if you need help with advancing. Different transfer equipment. We have transfer discs that can kind of turn. You can see just her foot is on there. That's just to help pivot. We have sit to stand aids, which helps, you actually sit to stand. It just gives you something to pull up on, and then you can swing that whole device. And then Hoyer lifts are our traditional mechanical lifts if somebody cannot stand up and you cannot physically transfer them anymore. Those usually work with a sling. And then checking your community for equipment. If you are unable to pay or your insurance doesn't cover, you can check with your doctor's offices, churches, lending closets. I've also had a lot of people find success in OfferUp, Craigslist, Facebook Marketplace. Obviously, be mindful of scams, but I've had some people that have gotten good used equipment through there. All right, and we'll go through these last ones fairly quickly. Reducing fall risk is important. So you want to exercise, obviously, to maintain your balance and your strength. You can also have your healthcare providers, your doctors go over your medications. Sometimes those can make you a little bit dizzy or can lead to increased falls. You want to make sure you're getting your vision checked regularly. Vision is a huge part of our balance, as well as modifying your home environment. So removing throw rugs, eliminating clutter, adding night lights, putting grab bars in your bathroom, not the suction cup ones. Those are no good. Try to get something that is fixed to the wall. Chair transfers. The biggest thing with chair transfers is you want to scoot to the edge of your surface. That's the number one. The second one is having those feet nice wide apart and then bending forward. So that forward trunk lean is typically what is lost in the atypical Parkinson's or Parkinson's disease itself. So that's your biggest cue. You can have people that are completely dependent for standing from a chair and move to independent fairly quickly. And then you're going to push into that standing position. Again, if you're having issues or difficulty with that, talk to your physical therapist. They can walk you through it. The last one is bed mobility. This just shows how you would help someone. So you start on their back. Typically, you get them rolled over to their side, which is what 2 and 3 shows. Once they're on their side, you kind of see in 4, she's bringing those feet forward to the edge of the bed and actually dropping them off the bed. And that uses physics to help prop the body upright. So again, using body mechanics, not just trying to muscle somebody for transfers. We want to keep both the patient and the care partner safe and healthy, because if you end up injuring yourself, then it's pretty difficult to provide the care that you need. All right, I know I went through those last ones kind of quickly, but wanted to get through them. Thank you guys so much for having me today. Here's a picture of my puppies for something cute to look at. And now I'm ready for any questions you guys might have.
Thank you, Corey, so much for all of that great information. It's a lot to cover, but you covered a lot. And I'm sure there's so many more things that you could say about all of that. And also, I'm always grateful for pictures of cute dogs. So let's see, looking at the questions that we've been getting in as you're presenting, but also that we had received during registration. One is, can you speak to the appropriate exercise or exercise options when someone is in more advanced stages of disease? So say if they're in a wheelchair or they can no longer walk or they have limited arm movements. And then I guess a related question to that somebody brought up in the chat is, how important is exercise still once someone is more advanced or in a wheelchair?
So exercise is again, is important throughout our entire lives. It's just adapting our exercises to meet the needs or meet our functional status. So once someone is pretty advanced or in a wheelchair and they can't stand, you still might be able to get them to do small movements when they're lying down or from that sitting position. The biggest thing is going to be stretching or range of motion exercises at that point, if they're pretty rigid and can't really actively move. So you would go to your physical therapist. We would teach you a range of motion program. So this is how you're going to go through the entire body, moving all the joints in every direction that they can. So that way they don't get stuck, or we don't have risks of what we call contractures, where the joints actually fuse. So that's going to be your biggest thing, is maintaining the range of motion. And if they're unable to stand, maybe even giving the opportunity, if they have the range of motion to stand, helping them stand in a supported way. So there are different standing frame devices that we have. Obviously, physical therapists, we're trained to help support people, and we can help care providers also help someone do that, because standing is going to be the best way to maintain ankle range of motion and the ability to stand and the ability to even sit comfortably in your wheelchair, as well as giving your bones some weight bearing capacity to maintain bone integrity and mass, bone mass. So it's definitely important. It's just the how do we get there? That's more of the question, and that just depends on, everybody's different.
Absolutely. And so it sounds like there are options for when someone is in more advanced stages, but it's also very individualized. So,
yes.
Yet another reason to work with a physical therapist on what exercise makes most sense for you and your needs.
Exactly.
And then kind of related, but sort of broader, I'd love if you could speak a little bit more to options for cardio exercise. And, for me, part of this comes from, we know the incredible importance of higher intensity cardio exercise for neurodegenerative diseases and in general. But, as you mentioned with PSP and CBD, there can be a lot of postural instability. There sometimes can be impulsivity or difficulty with judgment and sort of navigating space related to that. And then with MSA, as you mentioned, there's the neurogenic orthostatic hypotension, so the decrease in blood pressure when somebody stands up or has positional changes. So there's sort of a tendency that I see for exercise classes mostly to focus on seated exercise and kind of lower intensity exercise, even though we're saying you really need, full body, higher intensity cardio for it to have the kind of impact that we want it to have. So, if you could talk more about how to kind of reconcile those two, like to get that higher intensity exercise while being safe, that would be great.
Yeah, that's a tough one. I get that question a lot. I think the recumbent bikes are good options. A lot of times too, they have seat belts, or you can kind of make some sort of harness system if there is an attachment to help assist with any sort of core stability issues. In here, if I'm seeing somebody, again, I usually use our harness system. So that's the beauty of coming into a physical therapy, or if you can get into like an adaptive gym program that they have those pieces of equipment. That can be beneficial. It gets you walking, which is obviously a functional activity. But you're right, it is hard. And sometimes we even use, arm ergometers, or even just the basic floor cycles that people have. They're not the greatest, but they work. The other thing is you can get your heart rate up in a sitting position if you just move kind of one after another. So seated cardio classes, I think, are good options if you can kind of work at that pace that you need. But if you're working, arm bike is going to get your heart rate up a little bit faster than a traditional leg bike if you're, lower level.
Yeah. Okay, great. Thank you. And a question that just came in that I guess is kind of related to that is doing water therapy appropriate, like water walking or aqua yoga, things like that, which can sometimes be higher intensity, but can sometimes also be a little bit safer because you can't really fall in while you're in the water.
Yeah, water aerobics and water fitness classes are great. Obviously, when you're in the water, you have some natural resistance from the water, but at the same time, you have some buoyancy because of the water. So depending on, again, how fast you're moving, they even have little weights and stuff that you can use in the pool. So walking, especially walking in multiple directions, if you're able to, is a really great way to exercise. And then, if you're really having balance issues or whatnot, I still recommend having somebody right there next to you, right in the pool next to you for safety. But there's definitely nothing wrong with water aerobics or water classes at all. They're good options.
Although I will add with that, and maybe you could briefly speak to it, if for someone who has multiple system atrophy though, or maybe one of the other diagnoses, but might have some blood pressure issues, that you do have to be extremely careful, especially getting in and out of the water, because it changes the pressure in your body and can make people feel really faint or dizzy or actually, have an extreme blood pressure drop.
Right. That's a really good point. Yeah. So again, I would definitely, if you're getting in and out of the water and your disease is a little bit more advanced or having the blood pressure issues, have somebody right there with you. Don't just try to venture or try it out on your own.
Yeah. And take it slowly, like you mentioned earlier with the blood pressure too. Kind of, get up and kind of let things even out before you move forward.
Correct.
A question that we get a lot, and it's a loaded one and it's very individual, and I have 4 minutes to ask you. We have a lot of questions that have come in, and I'll try to focus on maybe these two really big ones. So one is, how do you know when it's the right time to be assessed for the appropriateness of an assisted device? Like, how far in advance should someone be thinking about that?
It does depend. So with our kind of process here at UCSD, we actually see people as soon as they're diagnosed. So with these atypical Parkinsonisms, it can take a while to get diagnosed, which is the tricky part. So as soon as you have that diagnosis, or even before that, we will be able to, just looking at you or assessing you, we'll be able to tell you at that point in time what assistive device we recommend and why. That may change, again, over the course of the disease. But if you're having falls or even balance issues, we're not going to automatically just go to a wheelchair. There are other devices, there are other options. So I wouldn't say there's necessarily a right time that you should wait until you're having frequent falls, or you should wait until you feel off balance. Just go see your physical therapist and they'll be able to tell you, this is what I think you need right now, and go from there. And then having those periodic check-ins. So again, we see people, we evaluate, we discharge, they come back 3 to 6 months later. And that way we can address things then as well as they come up or before they come up, that sort of thing.
Yeah, exactly. I mean, to me, what I'm hearing in that is it's about being proactive rather than reactive with that.
Exactly.
And then a really big question that did come in, but it's so important, and I definitely want to ask you in our last 2 minutes, so just being mindful of that, is, it's sort of rare to find physical therapists or other allied health professionals who are really specialized in PSP, CBD, or MSA. They might come and see you all, but then go back to their local community or see a home health PT. And a lot of patients and families find themselves educating their own providers about their diagnosis. So what suggestions would you have for how they talk to a physical therapist or other rehab professional who might not be as familiar with these diagnoses? Like, what should they be telling them in order to get that high quality care that they need?
Yeah, I mean, that's a tough one. First, I would try to find a physical therapist, if you can, that has neurological training. So there are neurological clinical specialties. So they'll have NCS listed after their name. There's actually a directory too that you can look for. Or if you can find a therapist that's maybe trained in Parkinson's disease. So you can see there's a lot of overlap with those Parkinson's. So trying to find the right provider first. In the event that you cannot find someone with that advanced training or knowledge, just I know that the CurePSP has different handouts and resources for clinicians, because I've looked at them. I've actually had patients bring them to me, not knowing that, I specialize in this sort of thing. And it really is a great resource. So it goes over the handouts or the motor impairments and has a handout of things that you can kind of generalize or look towards. At the end of the day, I think physical therapists, we are trained to treat impairments, not necessarily the disease. So hoping that you find a good one that does that. And then any specific goals or things you're having trouble with, communicate those to them. And then hopefully, they'll do some research on the back end on their own to know exactly what the disease is, what things they should be looking at. But yeah, using those resources that the CurePSP has, I think would be really easy to do or mention.
I really appreciate you mentioning that. Maybe one of my colleagues could put that in the chat for folks. We even have a brochure specifically for allied health professionals, the goal of educating them on these diagnoses. And then a lot of times people will bring the some answers packets too. But ultimately, like you said, it's about treating somebody's individualized symptoms and care needs and goals rather than the diagnosis itself, but having that sort of baseline understanding of at least neurological diseases or Parkinsonism is a really good first step. So we are at time and we have our research panel next, but Dr. Corey Troyer, it has been a pleasure. And again, thank you for your time and sharing such incredible and tangible information for our community today.
Yeah, thank you guys for having me. It's been a great opportunity for me. I appreciate it.